Good evening and welcome to session 1 of our virtual patient education series, 2020 New and Emerging Treatments for Blood Cancers. Thank you so much for joining us this evening. My name is Carrie Callis and I am the Director of Programs at the Leukemia Research Foundation. We're pleased to present this event in partnership with the Cardinal Bernardine Cancer Center at Loyola. We typically have this event in person, but because of obvious reasons, we moved to a virtual format and we really appreciate you adjusting to this virtual setting. We would like to thank our supporters this evening, AbbVie, Jazz Pharmaceuticals, Karyopharm Therapeutics, and Novartis Oncology. As a brief background about the Leukemia Research Foundation, the Foundation's mission is to conquer all blood cancers by funding research into their causes and cures and enriching the quality of life of those touched by these diseases. Since its inception in 1946, the Foundation has funded over $80 million of research grants to over 500 new investigators on 5 continents and supports patients and families living with a blood cancer diagnosis through educational and support programs. I encourage you to visit allbloodcancers.org to learn more about our patient support programs and resources, including our online support community and our comprehensive listing of resources. At this time, I would like to introduce our moderator of tonight's program, Dr. Patrick Stiff from Cardinal Bernardine Cancer Center at Loyola. Dr. Stiff is the chair of the Foundation's Medical Advisory Board, and we thank him for all he does to advise and support our work at the Foundation, as well as for moderating this program tonight. So I'll turn it over to you, Dr. Stiff, at Loyola. We typically have this event in person, but because of obvious reasons, we moved to a virtual format, and we really appreciate you adjusting to this virtual setting. We would like to thank our supporters this evening, AbbVie, Jazz Pharmaceuticals, Karyopharm Therapeutics, and Novartis Oncology. As a brief background about the Leukemia Research Foundation, the Foundation's mission is to conquer all blood cancers by funding research into their causes and cures and enriching the quality of life of those touched by these diseases. Since its inception in 1946, the Foundation has funded over $80 million of research grants to over 500 new investigators on 5 continents and supports patients and families living with a blood cancer diagnosis through educational and support programs. I encourage you to visit allbloodcancers.org to learn more about our patient support programs and resources, including our online support community and our comprehensive listing of resources. At this time, I would like to introduce our moderator of tonight's program, Dr. Patrick Stiff from Cardinal Bernardine Cancer Center at Loyola. Dr. Stiff is the chair of the Foundation's Medical Advisory Board, and we thank him for all he does to advise and support our work at the Foundation, as well as for moderating this program tonight. So I'll turn it over to you, Dr. Stiff.
So thank you all for participating. This is going to be saved and archived for future use, and you can review it back on the screens on your home computers or wherever you want to look at these talks and refresh your memories, etc. in the future. Next, I'd like to introduce Dr. Patrick Hagen, who's going to talk about the other terminally differentiated B-cell malignancy called multiple myeloma, another very common yet difficult to treat at times blood cancer. Dr. Hagen is Assistant Professor of Medicine in the Division of Hematology Oncology at my institution, Loyola, and he's a member of the bone marrow transplant program. He's in the process of developing 2 new national trials that are going to test some new treatments in multiple myeloma in the NCI-sponsored cooperative group system, and you'll hopefully be hearing about these over the next 6 months or a year.
Thank you, Dr. Stiff, for the introduction, and thank you to the Leukemia Research Foundation for having me. It's always a pleasure to come and give these talks, and like the others have mentioned, you know, it's great to be together, but this does give us a unique opportunity to expand our reach and have more people involved. So it's always a pleasure, and I always feel pretty lucky to be in such good company. So So I'm going to talk about multiple myeloma and kind of get going pretty quickly, because for good for patients, but for bad for a 20-minute presentation, a lot is happening in myeloma that's really improving patient care. So this is kind of what I'm going to go over. I'll just touch a little bit about how we risk stratify myeloma, because that does dictate what we might expect our patients to achieve with therapy. Then we're going to talk about current landscape in the initial therapy for newly diagnosed patients, move into a myriad of new drugs that have been approved or in the process of being approved in the relapse setting, and then kind of just briefly touch on overall improved outcomes. I think it's important to know where we started to kind of really realize where we've come. We've known about this disease for almost 200 years. This is from a journal with the first reported case of myeloma in the medical literature, a young woman named Sarah Newberry, who would pass away about 4 years after the onset of her symptoms. At that time, these were the treatments for multiple myeloma, and these really didn't change much about the next 100 years. Things like orange peel, Dover powder, rhubarb pills, and actually leeches were used as the first quote-unquote maintenance therapy. So as you'll see, we've come a long way. When you're talking about myeloma with your doctor after diagnosis, one really important thing to understand is what is your risk. And unlike other cancers, staging or risk stratifying myeloma is different. This is a cancer that comes from the bone marrow, the plasma cells. These are cells that make good antibodies, which is depicted up here on the top right. And over time, as they divide, mutations and mistakes happen in the DNA, which make them become cancerous. And it's those mutations particularly that dictate how our patients might do. And you heard that in the last presentation. It's the FISH, or the cytogenetic, the genetic mutations in the cancer cell. And so not all myeloma patients are created equal. This is on the right, you'll see a table with our old staging system, something called the ISS, and then our new staging system down here on the bottom right, something called the revised ISS staging system. Unlike CLL, we generally do need a bone marrow biopsy to diagnose myeloma, and that, in addition to blood tests, allows us to tell you how we might expect you to do with therapy. There are some known high-risk features, so these FISH changes, these are listed down here, cytogenetic FISH changes. So things like a 17p deletion that you just heard about in CLL also is high risk in myeloma. And then we look at other things, other blood tests like your LDH or your beta-2 microglobulin. And with this information, we're able to tell you your stage. And as you can see, although myeloma patients are doing great, those with high-risk features, unfortunately, still are not living as long of a life as we'd like to see. So more work to be done. It's important, too, because this staging system is applicable to patients who are undergoing transplant in their initial therapy or not, those who are treated with a certain class of drugs called IMiDs, and I'll talk a little bit more of that, or proteasome inhibitors. So overall, no matter which way your therapy goes, this staging system impacts outcomes. So let's move into therapy. So we're going to start with kind of our older therapies used in the initial treatment. The initial therapies in myeloma were largely steroids and what we call alkylating agents. These are chemotherapy drugs. They make the cancer DNA unstable. The early drugs were melphalan and cyclophosphamide. Some later drugs were introduced, such as busulfan. And melphalan remains actually the backbone of stem cell transplant, and it can still be used in the relapse setting often. There's a new kid on the block I'll talk about in the end called melflufen, which is a new type of alkylator. Next, we have proteasome inhibitors. So unlike alkylators, these are more specific to myeloma cells. Alkylators are basically chemotherapy. Proteasome inhibitors really target more in on the actual myeloma cancer cell. They cause basically a part of the cell to become unstable, which causes the cell then to die. The first drug that we had in general use was a drug called bortezomib or Velcade. This is part of the RVD, kind of your standard induction. Later generations were developed, such as carfilzomib, ixazomib, and then there's a couple more that are in clinical development right now listed here on the bottom, borizumab and aprozomib. The next big class of drugs we have in myeloma are called immunomodulators. So the best well-known one in myeloma is a drug called Revlimid, listed down here under later generations. The early drug, and this data is wrong, so excuse me, was a drug called thalidomide, which is not used as much in the United States, more so in Europe and around the world. These drugs are very good. They engage the immune system. to attack the myeloma. They do a number of other things in the way they work, and unlike alkylators, again, they're more specific, so they're better tolerated. The kind of newest kids on the block, they're getting old now, are monoclonal antibodies. So these are basically antibodies that we generate that target the cancer cell. So again, unlike chemotherapy, these are more targeted. They have less side effects. The early drug that was developed was elotuzumab, which was improved in 2015, and subsequent daratumumab, and then most recently, just this year, isatuximab. Daratumumab now has really changed the landscape of myeloma therapy. So those are our drugs. So as of 2020, I think there's some important tenets to understand. Multiple myeloma is a chronic disease. It's not a disease we can cure. So in my opinion, there are really three goals. We want to get you into remission. We want to keep you in a remission for as long as possible, and we want to do so with the least impact on your quality of life. So how do we do that? It's a three-step process. We induce, or we use a combination of drugs to get the myeloma into remission. Then we consolidate, or we try to deepen that remission, and that's typically done with high-dose melphalan and transplant. And then we need to keep you on maintenance to maintain that remission for as long as possible. Because again, as of today, the vast majority of myeloma patients, this is a chronic disease. And we would highly encourage every patient to participate in clinical trials. This is your best chance at an improved outcome. And it's the way we move the field forward. So at every step of the way, you should be asking your doctor, is there an opportunity to be involved in a clinical trial? So in terms of the induction, or the first step, really it's a 3-drug regimen, a combination of 3 drugs that's used. The backbone is always a steroid, dexamethasone, and in almost all cases, a drug called lenalidomide or Revlimid. This is one of the IMiDs I mentioned earlier. Then the question is, what should be the 3rd drug? And there's been a lot of recent data that I'll go over briefly here. So a question you might be asking your doctor is, well, if I'm going to get Revlimid and dexamethasone, what might be the best 3rd drug for me? Well, we thought we knew, so we did a big trial recently called the Endurance trial, which compared KRD, so that's carfilzomib, with Revlimid and dexamethasone, one of the proteasome inhibitors, with a combination called RVD or VRD, so that's Velcade, one of the other proteasome inhibitors. And as you'll see, this top is the progression, this bottom is the survival, and there was no difference. So there were differences in toxicities, but again, as long as you're getting a 3-drug regimen, you're on the right path, and then you need to look and talk with your doctor about what that best 3rd drug might be. This was just published this year. There was another recent publication in the last year, a trial called the Maya trial, and this looked at adding daratumumab as your 3rd drug. So that's one of the new kids on the block, one of those monoclonal antibodies, very well tolerated. And this was daratumumab. This graph you're seeing above, and we added it to our just Revlimid and dexamethasone, and we've seen very good outcomes. So the median progression-free survival and time to progression wasn't reached, and at 30 months, almost 3/4 of patients on the daratumumab had not progressed. So what's the answer? The 3rd drug really depends on a couple of things. Daratumumab is not approved as the initial therapy in patients with the intent to head to transplant. That's a big question. Next question is, what are the potential toxicities? So carfilzomib has issues with the heart and raise blood pressure. So if you have those problems, that drug might not be right for you. If you have diabetes and you have neuropathy, the Velcade or the bortezomib might not be the right drug. And in general, we do need to consider the ability to tolerate 3 drugs. Some of our patients who are older and more frail can't do it, and doublets in those cases or 2 drugs are okay. Sometimes we'll use something called RVD light, seen at the bottom here. That's just basically a dose reduction of our standard triplet. And there are clinical trials now that are being designed to look at this. So the next question you might be asking in your initial therapy is, in today's world, with all these new drugs, do I still need a transplant? Well, I'm a hammer and transplant is a nail, so my answer to that is yes, but the data would back me up. So these are 4 trials that have been done and recently published. All of these trials compared upfront versus delaying high-dose chemotherapy and transplant as consolidation. And every single trial shows about a 1.5 year progression-free survival advantage, and some of the trials show an overall survival advantage. And ironically, just today, there was a paper published by the EBMT, or the European Bone Marrow Transplant Group, and they looked at all the data, and everybody is still recommending this. So the answer is yes, every patient should at least be evaluated for the role of high-dose melphalan in autologous stem cell transplantation. Not everybody will be a candidate, but it should be offered to all patients. And we need to stop doing the studies, but that's just my opinion. So doctor, this is another question I get. If I'm in a deep remission after transplant, do I need to continue therapy? Again, the answer to that we'll get to here. So myeloma is a chronic disease. We have to engage the immune system in surveillance to keep the disease from relapsing. So this is the role of quote unquote maintenance after your transplant. And we're seeing that when we do maintenance, we're seeing improved times of progression by, again, at least 1.5 years and probably longer. And in a recent meta-analysis where we looked at all these big studies that looked at maintenance, there was an improved survival. So this is depicted here on the top. So the blue is patients who get maintenance. The yellow is the patients who don't. So there's a big difference in progression. And down here is survival. So what are the next steps? We do need to do some risk-adapted maintenance approaches, and these clinical trials are ongoing. So the answer is, do you need maintenance even if you're in deep remission? I would say the answer to that is definitely yes if you want to stay in remission. And it's very likely that this will improve your survival. And that's being studied by studies such as the MASTER trial, which is looking at patients who are able to get into really deep remissions for a long time. Can they potentially stop? And then we have a big trial in SWOG that's looking at modifying the maintenance based on how patients are responding over time. These are important questions that are being asked. A few notes on supportive care. So this is critically important in myeloma. It's a disease of the immune system. So there's lots of bone problems. So you should talk to your doctor about calcium and vitamin D. You should be on some medications to strengthen your bones, typically for at least 2 years once you're diagnosed. So something else to be aware of in talking to your doctor. There's a high risk of blood clots. So most patients need to be on aspirin or some sort of a blood thinner to prevent this. Infections are a big problem. So being on preventative anti-infectious agents is important. And finally, critically important is vaccination, so against things like shingles and pneumonia. So these are all things you should be talking to your doctor about, and they should be managing with you. So that's upfront therapy for myeloma in less than 10 minutes. Now let's try to cover relapse therapy in myeloma, where the landscape is really changing quickly. Again, just like upfront, I would encourage all patients to participate in clinical trials. At least discuss it with your doctor. It's not right for everybody, but it should be discussed, and there are lots of opportunities. Many of the same principles apply when the disease comes back. So right now we're getting on average 4 to 5 years up with our initial therapy, but eventually it comes back. And when it comes back, 3 drugs are still better than 2. We treat until progressive disease, and there's an ongoing importance of all that supportive care I just mentioned. There is really a lack of head-to-head clinical trials in the relapse setting to compare regimens, but we'll talk a little bit about what we know. So again, it's what drugs are right for you, what medical problems do you have, and what previous therapies have you had. So there really isn't one best treatment approach for any given patient. And treatment is, like I said, tailored to your comorbidities and your ability to tolerate therapy. And again, just like up front, when you're initially diagnosed, when you relapse, you should talk to your doctor about risk. You should be asking questions like, are there any new high-risk changes in my bone marrow? How long did you go from your initial therapy to your relapse? These are really what dictates long-term outcomes. So triplet regimen, our 3 drugs, are extremely effective in relapse disease. So these are just 2 studies where we looked at adding carfilzomib, again, a proteasome inhibitor, to Revlimid and dexamethasone, and we saw 26 months of time before the myeloma comes back. And then in a recent study just published this year in The Lancet, we did a study where we add that drug daratumumab to carfilzomib and dexamethasone. And again, the median time to progression wasn't even reached. So these are just very good active 3-drug regimens, good options for all of our patients when the disease relapse. Although we don't know which regimen is best, there have been some attempts to look at this. And so on the left, you're seeing all these different 3-drug regimens, some 2-drug regimens. And as this bar goes to the left here, on the right side, so what you'll see up here on the top, this daratumumab, lenalidomide, and dexamethasone triplet is being shown to be the best. But at the end of the day, these are not randomized trials. These just shows that there's a lot of good regimens, a lot of good treatment options out there for you. Another important thing to consider when the disease comes back, consider strongly, is a second transplant. Patients who go at least 18 months without maintenance, and definitely 36 months with maintenance, have really benefited from their initial transplant. And there's data that would say if they get a second transplant after a long remission, there's probably a survival advantage. This is why we collect enough for 2 transplants up front, and this is something we're actively trying to study actually right now in SWOG. So to finish up, what about the new kids on the block? There's been a lot of action recently in myeloma, a lot of new drugs. Let's go through them, at least overview, and we can talk more in the questions. So melflufen, this is an alkylator just like those original chemotherapy drugs, but it works a little different. Here in this slide, what it's showing is melflufen is actually bound to a carrier. It enters the cancer cell, and cancer cells have more of these peptidases that cleave the carrier. The melflufen then gets stuck inside the cell and does a better job of killing it. So it allows us to basically give less of the drug and have it be just as effective. So this is a really exciting new drug. There's been a bunch of studies. The Horizon study was a phase 2 study. The Ocean study was a phase 3. And right now this drug is under priority review from the FDA and likely to be approved soon. The next new class of drugs are called antibody drug conjugates. So these are basically like a loaded gun. We take an antibody that can find the myeloma cell and we put a toxin on it and it finds the cell and kills it. Belantamab, which was just approved, is the most well known. But right here you'll see these are all drugs that are in development that work this way. So we'll talk about belantamab on the next slide, but there's a lot upcoming. Belantamab basically, again, is an antibody that binds something called BCMA on the cancer cell, which is shown over here on the right. And attached to it is this toxin. So it binds, the toxin goes into the cell and kills it. It also engages the immune system as well. Belantamab has shown really promising phase 1 and phase 2 data, and now is approved. It had a response rate of 30%, and those who responded for 11 months. So this drug is looking good. It has unique ocular toxicity of the eye, so that's something you need to be aware of. Next is a class of drugs called nuclear export inhibitors. The approved drug is a drug called selinexor. These drugs work by there's basically a receptor that gets rid of these proteins called tumor suppressors that prevent the cancer cell from dying. So the drug blocks these receptors, and then the cell is able to do its normal dying process as the body recognizes that it's a cancer. The STORM trials is what's got this drug approved. It had a response rate of about 20%, the duration of response about 4 months. The Boston data is a study that's well known, combining it with a drug called Velcade or bortezomib that we mentioned earlier. And right now there is basically a large group of trials where they're combining this drug with a lot of other drugs. It is toxic. It has a lot of toxicity. It can be tough to take, but when dosed right and in the right patient, it is a good drug. So the next group of drugs are the multi and bispecific engagers. The one that I'm going to talk about is a drug called AMG 701, but there's a number of these. Just like with those antibody drug conjugates, here's about 10 drugs that are in clinical trials that are looking promising. So a lot more to come here. How do these drugs work? So basically we take an antibody that combines the myeloma, combine the tumor cell, and combine to your immune system and engage it. So the tumor cell is brought to your immune system, which proliferates and then kills it off. There are a variety of phase 1 and 2 studies underway, and there's a lot more to come. And then finally, kind of the hottest topic in myeloma therapy is CAR-Ts. So what are CAR-Ts? Essentially, these are your own lymphocytes or white cells that are taken out of your body and then are engineered to fight the cancer. They recognize a receptor on the cell, something called BCMA that I mentioned already several times. And after the cells are taken out of your body, they're engineered to then attach to that receptor, that BCMA receptor, grow and kill off the cancer. So this has been used heavily in lymphoma and then in ALL, and as we just heard, it's being explored in other cancers such as CLL. The myeloma, the data has looked really good. So this drug, BB2121, was published in the New England Journal, a phase 1 study. These were heavily pretreated patients, a median of 7 lines. There are some unique toxicities that you need to talk to your doctor about. This isn't right for everybody. But we saw unprecedented responses, a CR rate of 45% in patients who had 7 lines of therapy, and PFSs of approaching a year in those who are responding. Patients are relapsing though, so this probably still isn't curative. There are many ongoing studies that I'm not going to go into here, but this just shows the landscape. It's ever expanding, and I created this slide a few weeks ago, and it's probably changed since then. 2 drugs are likely to be approved in this coming up 2021 year. So more to come. This will be part of the landscape. And then finally, a bunch of drugs that I'm not going to go into any detail in lieu of time are being developed, some of which you heard in the last talk, venetoclax and ibrutinib, and many others that look promising. And I'll leave you with this slide. So this is a really important slide to see. So this is basically cancer registry data, and it shows that patients of any age group less than 65, 65 to 74, or greater than 75, And in all racial groups, whites, Hispanics, and blacks, survival over time is going up. So for those less than 65, it's gone from 38 to 61% in 5 years. For those in 65 to 74 years old, it's gone from 29 to 48%. And even in our most elder patients, it's improving. So with that, hopefully I didn't cover too much too quickly, but it's a really changing landscape very quickly, and there's a lot of exciting things that I didn't cover and many more things to come.